were discussing about amino acidopathies. I had just started in the last class. So continuing that. So you just learned that amino acidopathies means inherited defects in the catabolism of intermediates of amino acid metabolism due to some enzyme deficiency. So they are called amino acidopathies. They may cause organic acidemias, hyperammonemias, and are only neurological signs. So organic acidemias, hyperammonemias, neurological signs, maybe any of them or all of them may be the manifestations of these amino acidopathies, which are due to defect in the enzyme that catalyzes an intermediary reaction in the metabolism of an amino acid. The organic acidemias. So one of them, the organic acidemias, they're caused by alpha ketoisocaproic acid dehydrogenase, alpha ketoisovaleric acid dehydrogenase, or alpha keto beta methyl valeric acid dehydrogenase. So that's what these three types of, they are because of the defective branch chain amino acid metabolism, where their keto acids are not further metabolized due to the deficiency of alpha keto acid dehydrogenase. During neonatal period, these disorders may produce severe illness with rapid deterioration associated with metabolic, neurological impairment, and excretion of urinary keto acids. Metabolic acidosis, neurological impairment, and excretion of urinary keto acids. We'll go into the details later. Acidosis and neurological impairment may produce severe illness with rapid deterioration with neutropenia, thrombocytopenia, and dehydration mimicking sepsis. Associated hyperammonemia. Ammonia may be associated, hyperammonemia may be associated with it due to the inhibition of mitochondrial carbonyl phosphate synthase. So the rate limiting enzyme of urea cycle may be inhibited. So that leads to hyperammonemia associated with the organic acidosis. Hyperammonemias due to deficiency of urea cycle enzyme. So second, organic acidemias, you've seen that the organic acidemias, hyperammonemias, and their only neurological signs may be the manifestations of these amino acidopathies. So now coming to the hyperammonemia due to the deficiency of urea cycle enzymes. So they, along with organic acidemias and glycine cleavage enzyme deficiency, are major causes of neurological deterioration in infants. Ammonia-induced coma of even 1 day duration can greatly impair the neurological development and intelligent quotient. Symptoms of ammonia intoxication include tremor, slurred speech, blurred vision, coma, and ultimately death. So these are the symptoms of ammonia intoxication: tremor, slurred speech, blurred vision, coma, and ultimately death. Ammonia is toxic to the brain in part due to conversion of alpha ketoglutarate to glutamate. So normally alpha ketoglutarate in the TCA cycle is converted to succinyl-CoA with the production of NADH. So that produces 3 ATPs, and subsequently also the other enzymes produce NADH, and a substrate level phosphorylation also is the succinate thiokinase, malate dehydrogenase. So those ATPs are not produced. So as a result, then this glutamate is diverted to glutamate. So note, it cannot be processed further in the TCA cycle. So impairment of the ATP that would have been produced otherwise in the neurons. That's why ammonia is toxic to the brain. The deficiencies of all the 5 enzymes of urea cycle are described. What are the 5 enzymes? Carbonyl phosphate synthase, ornithine transcarbamylase, argininosuccinate synthase, argininosuccinase, and arginase. The 5 enzymes, any of them may be defective. Ammonia intoxication is more severe when the metabolic block occurs at the reactions 1 and 2, that is carbonyl phosphate synthase 1 and ornithine transcarbamylase. And the third reaction, when the citrulline is formed already, some ammonia is already removed. You've seen that the carbonyl phosphate synthase, first one, and then argininosuccinate synthase here, citrulline then is formed. So some ammonia is already removed, thereby the severity is reduced, whereas the deficiency of the first 2 enzymes leads to severe types of hyperammonemias. So clinical symptoms of all urea cycle disorders include vomiting, avoidance of high protein foods, intermittent ataxia. Ataxia means the gaze cannot be fixed. So the eyes they move, and they cannot walk in a straight line. That is intermittent ataxia. Irritability, lethargy, laziness. The child will not be interested to do anything. He will be inactive, dull, and severe mental retardation. So these are the symptoms of urea cycle disorders. Vomiting, avoidance of high protein foods, because whenever he takes high protein diet, it cannot be metabolized, and so vomiting occurs. That's why he will avoid high protein foods. Intermittent ataxia, irritability, lethargy, and severe mental retardation because of the neurological symptoms. Encephalopathy. The infants initially appear normal at birth, then progressively manifest the symptoms. Hyperammonemia without an acidosis is highly suggestive of a urea disorder. Whereas hyperammonemia with acidosis, you have seen branch chain keto acid dehydrogenase deficiency, organic acidemias. Urine amino acid analysis or enzyme analysis may have to be done for specific diagnosis. Hyperammonemia causes a secondary elevation of glutamine. This is about hyperammonemias. So, coming back to the alpha keto acid dehydrogenase deficiency, which causes maple syrup urine disease. So, maple syrup urine disease is due to the deficiency of branched chain alpha keto acid dehydrogenase. Now, transaminase converts the branched chain amino acids valine, leucine, and isoleucine into their corresponding keto acids. So, transamination converts them. Leucine is okay. So, leucine, this is alpha amino isocaproic acid, acetic, propionic, butyric, valeric, caproic. So, alpha amino isocaproic acid. So, it on transamination produces alpha keto. Amino group is removed. That's also alpha keto isocaproic acid. Similarly, valine is alpha amino isovaleric acid, produces alpha keto isovaleric acid. Isoleucine is alpha amino beta methyl valeric acid that produces alpha keto beta methyl valerate. So these are all the keto acids, you can see these keto acids. Then they are to be acted upon by alpha keto acid dehydrogenase, which is similar to pyruvate dehydrogenase and alpha keto glutarate dehydrogenase. What are the 5 coenzymes necessary for these enzymes? Any of you remember? Thiamine pyrophosphate, lipoic acid, coenzyme A, NAD, and FAD. So the 5 coenzymes are necessary. Same enzymes are here. So here only coenzyme A is depicted. So coenzyme A and decarboxylation. So this is oxidative decarboxylation is caused by this alpha keto acid dehydrogenase. So same enzyme or different enzymes. So action is similar. That's why and most of the times all the 3 metabolic pathways are impaired. That's why it might be a single keto acid dehydrogenase that acts here. So these products cannot be produced. There will be alpha keto acids and the amino acids they accumulate. Inherited deficiency of this enzyme results in the accumulation of branched chain keto acids and also amino acids and their excretion in urine. Branched chain keto acids give a peculiar sweet odor, maple syrup, that is burnt sugar. That's why this is called maple syrup urine disorder, or urine disease. The condition is associated with the neurological symptoms and there may be metabolic acidosis. Early detection, and there can also be, as you have seen, hyperammonemia also can be there because they can be there because of inhibition of carbamyl phosphate synthesis. That's what you see. So early detection and dietary restriction of branched chain amino acids can prevent the severe psychomotor disorder. Definitive diagnosis relies on the demonstration of branched chain keto acid decarboxylase deficiency in leukocytes or cultured fibroblasts. So these are easily available. So leukocytes or fibroblasts that are cultured, you can utilize them and demonstrate the deficiency of branched chain keto acid decarboxylase, which will be diagnostic. So coming to the second amino acidopathy, non-ketotic hyperglycinemia. This is due to defect in glycine cleavage enzyme, so which is a rare inborn error. Glycine cleavage enzyme. So this is the action of this glycine cleavage enzyme. So in the presence of the tetrahydrofolate, this tetrahydrofolate takes the 1 carbon, so it's converting it to N5, N10 methylene tetrahydrofolate. The ammonia is converted to ammonia, freed ammonia, and this carbon dioxide is converted to carbon dioxide. So that's all the atoms are metabolized by the glycine cleavage enzyme. Now, the deficiency, yes, so the deficiency of this enzyme results in increased glycine level in the blood, urine, and CSF. So, glycine cannot be metabolized. The glycine accumulates in the blood, resulting in its excretion into urine and also into the secretion into the CSF. Severe mental retardation and seizures, that is convulsions, are seen because glycine acts as a neurotransmitter. In moderate levels, it inhibits neuronal transmission, but at high levels, it causes overexcitation. So either way, it is a problem. So that's why glycine accumulation causes severe mental retardation and seizures. This is non-ketotic hyperglycinemia due to defect in glycine cleavage enzyme. Diagnosis is made by increased CSF is to blood glycine ratio. So there will be some amount of CSF glycine also, but there will be greater concentration of glycine in the blood. So there is the greater concentration of CSF, not in the blood. The increased CSF is to blood glycine ratio, increased glycine in CSF. Normally, we will see in other disorders, we will not see it in CSF. So here, we will see the other condition, hyperoxaluria, in that we don't see in CSF. Here it is seen increased quantities in CSF even than in blood. There is no effective management, but diagnosis is important for genetic counseling and preventing subsequent pregnancies, and such children will be a great burden to the families and to the nation. So they are to be counseled for not having any further children. So glycinuria is another disorder which is caused by renal tubular reabsorption defect. It is asymptomatic, so we don't consider it as an amino acid, then we don't discuss it also there. So we should be able to distinguish between the non-ketotic hyperglycinemia and glycinuria. So the glycinuria is a renal tubular reabsorption defect only, whereas non-ketotic hyperglycinemia is due to the glycine cleavage enzyme defect. So there is a third disorder associated with glycine metabolism, that is primary hyperoxaluria due to abnormal location of alanine glyoxylate aminotransferase. So apart from glycine cleavage enzyme, glycine can also be acted upon by either glycine oxidase or alanine glyoxylate transaminase to form glyoxylate. So either of them, they can produce glyoxylate. Now this glycine, which is converted to glyoxylate, part of it is also converted back to glycine. So here so much of glyoxylate is produced, some of it can be reconverted to glycine, is reconverted to glycine. Now, if this aminotransferase is not effective, so this reconversion of glyoxylate into glycine cannot take place, and this glyoxylate will be converted to oxalic acid, which will be excreted in urine, particularly when this formation also is impaired. So all glycine will be converted to oxalic acid. Oxalic acid is highly insoluble. It causes crystalluria. So accumulates in the urinary tract and causes renal stones. So that is, the enzyme is not defective as such. The location is defective. So normally it is present in the peroxisomes, but in these cases it is located in mitochondria. So this is called protein targeting defect. So the enzyme becomes inactive. It has to be in its proper place only. Instead of being present in peroxisomes, if it is present in mitochondria, it will not be of use. So if the eye is in the head, it's okay. If it is in the feet underneath, so it will not be of use. Similarly, it has to be in its proper place, only then it will be more effectively used. So this is called a protein targeting defect. That is the abnormal location of alanine glyoxylate aminotransferase leading to primary hyperoxaluria. So enzyme is inactive, and so there is excessive production of oxalate, renal deposition causing nephrolithiasis, impaired conversion of glyoxylate to formate also may be a contributory factor. In severe cases, extrarenal oxalosis may also be seen, and the oxalate stones will be deposited in heart, blood vessels, bones, etc. So this glycine metabolism should remember. So either glycine oxidase or alanine glyoxylate transaminase can convert glycine to glyoxylate, and if this aminotransferase is defective, some of the glyoxylate cannot be converted back to glycine, and so the glyoxylate will be converted to oxalic acid. which is contributed by this conversion, defective conversion of glyoxylate to formate also. So all the glycine is converted to oxalic acid, so which causes increased excretion in the urine and renal stones, or further increase in worse conditions. It may be deposited in the blood vessels, heart, and bones also, etc. So, fourth condition, phenylketonuria due to defective phenylalanine hydroxylase activity. Normally, phenylalanine is acted upon by phenylalanine hydroxylase. The enzyme 1 here converts phenylalanine to tyrosine in the presence of tetrahydrobiopterin, which acts as a coenzyme. So, deficiency will lead to phenylketonuria. And then the tetrahydrobiopterin is converted to dihydrobiopterin. And this dihydrobiopterin has to be converted, reduced back to tetrahydrobiopterin by means of dihydrobiopterin reductase. So its deficiency also can cause phenylketonuria types 2 and 3. And the synthesis of biopterin itself can be defective, which causes phenylketonuria type 4 and 5, which you have learned when I taught you about the amino acid metabolism. So phenylalanine cannot be converted to tyrosine, so phenylalanine accumulates. Phenylalanine level in blood is elevated. So now in phenylalanine cannot be converted to tyrosine, so it is subjected to transamination leading to formation of phenyl pyruvic acid, phenyl lactic acid, phenyl acetic acid, and its conjugate phenyl acetyl glutamine, which are excreted in urine. And this phenyl acetyl glutamine is responsible for the mousy odor of the urine. See the phenylalanine, now instead of being acted upon by phenylalanine hydroxylase, will be acted upon by transaminase. While converting it to phenyl pyruvate, so amino group is removed, keto acid is found, phenyl pyruvate. Phenyl pyruvate can be decarboxylated to form phenyl acetate, which can be converted to phenyl acetyl glutamine. Phenyl acetate conjugates of glutamine to form phenyl acetyl glutamine, which is responsible for the mousy odor of the urine. And also phenyl pyruvate can be converted to phenyl lactate. So because phenyl pyruvate and phenyl acetate are keto acids which are excreted in urine, this condition is called as phenylketonuria. Excretion of phenyl ketone bodies in urine. Phenylketonuria due to defective phenylalanine hydroxylase activity. So as phenylalanine concentration in blood is increased, it interferes with the synthesis of neurotransmitter dopamine, because this phenylalanine is converted to tyrosine. Tyrosine is then converted to DOPA to dopamine. So this dopamine is a neurotransmitter. Its synthesis is impaired, leading to mental retardation, convulsions, etc. And tyrosine also produces melanin. So this melanin synthesis is also impaired, as a result of which there will be hypopigmentation. The phenyl ketones present in urine give a blue-green color on addition of ferric chloride. So this is called the ferric chloride test. A blue-green color is given by this urine when to a few drops we add ferric chloride. Early detection and giving a diet low in phenylalanine during the first decade will prevent mental retardation. Normally, so this is the metabolic pathway of tyrosine. We will be learning about it now, just now later. Alkoptonuria, even may be associated with ochronosis due to homogentisic acid oxidase deficiency. So tyrosine transaminase converts tyrosine to para-hydroxyphenyl pyruvic acid. So tyrosine is acted upon by tyrosine transaminase to form para-hydroxyphenyl pyruvic acid, which is acted upon by hydroxylase or oxidase, para-hydroxyphenyl pyruvate oxidase, which requires copper ascorbate and oxygen. So it is converted to homogentisic acid, wherein there is an intramolecular rearrangement. So here it is shifted, side chain is shifted from C4 to C5, and then hydroxylation is brought about at C3, C4. So that is tyrosine. This is thus converted to para-hydroxyphenyl pyruvate, which is then acted upon by para-hydroxyphenyl pyruvate oxidase or hydroxylase to form homogentisic acid. And this homogentisic acid is then acted upon by homogentisic oxidase to produce mallyl acetoacetate, which is isomerized to fumaryl acetoacetate, which is acted upon by fumaryl acetate hydrolase to convert it to fumarate and acetoacetate that can be metabolized. So now homogentisic acid oxidase deficiency will result, homogentisic acid oxidase deficiency will result in accumulation of homogentisic acid. So deficiency of homogentisic acid oxidase results in accumulation of homogentisic acid that is partly excreted in urine and partly deposited in the joints, causing arthritis, and later leading to accumulation and accumulation of connective tissue, leading to connective tissue pigmentation, which is called as ochronosis, due to oxidation of benzoquinone acetate, which polymerizes, LY should be there, and binds to connective tissue. So homogentisic acid is converted to benzoquinone acetate, which then further polymerizes and binds to connective tissue. So that's why this leads to ochronosis, staining or pigmentation of the connective tissue, and arthritis because of its deposition in the joints. So urine darkens on exposure to air due to oxidation of homogentisic acid. Homogentisic acid is a reducing agent and so gives a false positive reaction with Benedict's reagent. So this is alkoptenuria or ochronosis. So here, not much of a neurological symptoms are also there. It's only urine darkens on exposure here. That's why the parents will come with the complaint. And this homogentisic acid is a reducing agent and so gives a false positive reaction with Benedict's reagent. So should not be mistaken as diabetes mellitus. Next condition is albinism. So albinism is due to generalized tyrosinase deficiency in deeper layers of epidermis and melanocytes. So you've seen that one of the metabolic pathways, tyrosin is converted to melanin. Here, two steps are catalyzed by tyrosinase. One is tyrosin conversion to DOPA and DOPA to dopaquinone. Both of them are catalyzed by tyrosinase, and the deficiency of tyrosinase will result in impaired production of or absence of production of no production of melanin, and so that's why there will be impaired pigmentation throughout the body. So that is albinism. So melanin will not be there. They look very fair. So even the ocular fundus is hypopigmented, so it will not be pigmented. And the iris may be gray or red. There will be associated photophobia, nystagmus, and decreased visual acuity. Hair is also white or gray. So leukoderma occurs due to a localized deficiency. Albinism is due to a generalized deficiency, tyrosinase deficiency, whereas here leukoderma occurs due to a localized deficiency of melanocytes or tyrosinase. Tyrosinemia type 1 is due to deficiency of fumaryl acetoacetate hydrolase. It is characterized by diarrhea, vomiting, a cabbage-like odor, and failure to thrive well. Infants die of liver failure because of accumulation of tyrosine in liver. Tyrosine, mainly fumaryl acetoacetate acetate, so backwards up to the tyrosine accumulation. They will accumulate in liver. There may be mild mental retardation. So here, mental retardation also might be there. In acute type, the child dies within 6 to 8 months, while in chronic variety, the child may survive up to 10 years. Plasma tyrosine levels are elevated and urine shows tyrosine. Tyrosinemia type 2. So type 1 is because of the deficiency of fumaryl acetoacetate hydrolase, tyrosine transaminase. Here, this is the tyrosinemia type 2, whereas this fumaryl acetoacetate hydrolase is type 1 tyrosinemia. So tyrosinemia type 2 is due to lack of tyrosine transaminase, which is also called as Richner-Hanhart syndrome, increased tyrosine in blood and its excretion in urine. So tyrosine is a very early step. So tyrosine transaminase itself is defective, so tyrosine is not metabolized at all. So increased tyrosine accumulates in blood and there is its excretion in urine. Mild to moderate mental retardation, dermatitis, and eye lesions. Some infants may exhibit self-mutilation, self-destruction. They bite themselves. Okay, they will continue now. It's 10 minutes I given the time. So neonatal, can you hear me? Hello?
Yes, sir. Yes, sir.
Okay.
Yes, sir.
Yeah. Neonatal tyrosinemia. Next condition, it is due to partial deficiency of para-hydroxyphenyl pyruvate hydroxylase, the second enzyme. Para-hydroxyphenyl phenyl pyruvate oxidase or hydroxylase. Deficiency will lead to neonatal tyrosinemia. And this deficiency may be transient. So blood levels of tyrosine and para-hydroxynyl pyruvate are elevated. Treatment for all the above involves feeding a diet low in protein, particularly low in phenylalanine and tyrosine, so the damaging effects of these amino acids is removed. So, of course, getting that diet becomes expensive. Amino acid hydrolysate or some specific diets are to be provided to these children. Infantile Parkinsonism. Tyrosine hydroxylase deficiency in sympathetic ganglia can cause defective synthesis of DOPA and of dopamine. If you recollect the pathway of, okay. So tyrosine is converted by tyrosinase to DOPA, DOPA to decarboxylase to dopamine, dopamine beta hydroxylase to norepinephrine, phenylethanolamine, N-methyl transferase forms epinephrine. So here, DOPA, tyrosine hydroxylase deficiency in sympathetic ganglia can cause defective synthesis of DOPA and of dopamine. Tyrosine hydroxylase cannot synthesize DOPA. It needs deficiency. So as a result of DOPA cannot be synthesized, and so dopamine cannot be synthesized, which is a neurotransmitter. Dopamine is a neurotransmitter. So dopamine deficiency can cause a progressive gait disorder and infantile Parkinsonism. Otherwise, adult Parkinsonism or the Parkinsonism in old age. So adult Parkinsonism is common, and there is death of dopamine producing cells in the substantia nigra, degenerative disorder as a result of age. So, and manifests around 60 years of age, presenting with occasional tremor in arms, a trance-like gait, stare, progressing to muscular rigidity, ataxia, and disturbing frequent tremors. And they will move. Initiation of movement will be very troublesome in these individuals. Life will be quite miserable. So this is because of death of dopamine producing cells in substantia nigra. Whereas infantile Parkinsonism is because of the deficiency of tyrosine hydroxylase. Pheochromocytoma, due to a tumor of adrenal medulla that secretes catecholamines. L, it should be L. So I told you the pathway just now of how the catecholamines are produced. So excessive catecholamine production leads to severe hypertension. So this is the tumor of adrenal medulla. So more catecholamines are produced, leading to severe hypertension, attacks of hot flushes, sweating, headache, and palpitation, and diarrhea that often occur following a meal. And this is not amenable to antihypertensive therapy. So the hypertension, severe hypertension, is not amenable to antihypertensive therapy, which is normally amenable. So the catecholamines and their metabolites such as metanephrine and vanillyl mandelic acid are excreted in increased quantity in urine. So you learned that catecholamines, they are metabolized by monoamine oxidase and the N-methyl transferase, converting it to vanillyl mandelic acid. So that is excreted in urine normally, and because of this tumor, more catecholamines are produced, more VMA is excreted. So that is VMA excreted in increased quantity in urine. The tumor is detected by CT scan, and surgical removal of the tumor is the treatment. So tyrosine hydroxylase, tetrahydrobacterin dependent. So DOPA is produced, and DOPA decarboxylase is converted to dopamine. So this dopamine further is acted upon by dopamine beta oxidase or hydroxylase, which requires oxygen, copper, and vitamin C for forming. So this is the hydroxylation is brought about here, forming norepinephrine. Then N-methyl transferase, so brings about methylation of this nitrogen. Here it is methylation, forming epinephrine. So pheochromocytoma is a tumor of adrenal medulla that it produces more catecholamines. That is, what are the catecholamines? DOPA, norepinephrine, and epinephrine. So more of them are produced. And this epinephrine, norepinephrine, they are metabolized to VMA that is excreted in urine, and also some amount of metanephrine. Cystinuria due to defective renal tubular reabsorption of cystine. So this is also associated with impaired reabsorption of arginine and lysine, and so they accumulate in the blood. So cystine being insoluble leads to recurrent stone formation and infection. Cystine can also combine with calcium to form larger stones that block urine, leading to recurrent infection or renal colic, causing pain in abdomen radiating to the leg. So this is cystinuria due to defective renal tubular reabsorption of cysteine, arginine, and lysine, and their accumulation in blood. And because cystine is insoluble, it forms renal stones. Hartnup disease due to defective intestinal and renal transport of tryptophan and other neutral amino acids. Because of transport defect, tryptophan and other neutral amino acids are not absorbed and so excreted in urine and feces. Their unavailability leads to mental retardation and ataxia. Impaired synthesis of niacin from tryptophan may cause pellagra-like symptoms, dermatitis, diarrhea, and dermatitis because tryptophan, you learned, produces niacin. 60 milligrams of tryptophan will produce 1 milligram of niacin, and so that is not there as a result. So niacin deficiency causes pellagra, and this pellagra is characterized by dermatitis, diarrhea, and dementia. So impaired synthesis of niacin from tryptophan as a result of impaired absorption of tryptophan produces this pellagra-like symptoms. So tryptophan by dioxidase is converted to formyl kynurenine, which by transformylase, the formyl group is removed, kynurenine. Kynurenine is by hydroxylase converted to 3-hydroxykynurenine. This 3-hydroxykynurenine is converted by 3-hydroxykynureninase, which is dependent on pyridoxal phosphate to 3-hydroxyantranilate, and this 3-hydroxyantranilate. Of course, the main catabolic pathway is converts to glutyryl-CoA and acetyl-CoA. Here, it diversifies. So 3-hydroxyantranilate can be converted to quinolinic acid to niacin, and NAD, and NAD can be formed from this. So a diverted pathway. So tryptophan leads to the synthesis of niacin or niacinamide in dinucleotides or its other coenzymes. So now when the tryptophan absorption itself is impaired, it cannot be metabolized. All these things cannot be produced. Particularly, niacin cannot be produced, leading to pellagra-like symptoms. And also because they are not available, so that leads to mental retardation and ataxia. They are not absorbed, it is excreted in the urine directly. Xanthurenic aciduria. Kynureninase converts 3-hydroxykynurenine to 3-hydroxyantranilate, which can be further catabolized to acetoacetate. That you have seen. So 3-hydroxyantranilate, 3-hydroxykynurenine is converted to 3-hydroxyantranilate by 3-hydroxykynureninase, which requires pyridoxal phosphate as a coenzyme, which is not shown here. So when there is deficiency of pyridoxal phosphate, kynureninase will not be able to function, and so 3-hydroxykynurenine is converted to xanthurenic acid, which is excreted in the urine. So that is called xanthurenic aciduria, particularly following a load of tryptophan. So this is the basis of tryptophan load test. And here you should also remember a condition called vitamin responsive genetic disorder, where this kynureninase may not be requiring normal amount of pyridoxal phosphate, but huge amount of pyridoxal phosphate only will be able to act as a coenzyme for kynureninase, and such conditions can be cured by pyridoxal phosphate. So that is called genetic responsive disorder, vitamin responsive genetic disorder. So when 3-hydroxy-pyridoxal phosphate or 3-hydroxykynureninase is defective, and anthranic acid is not found, but xanthurenic acid is found, which is excreted in urine. So that is the basis of xanthurenic aciduria, particularly following a tryptophan load. So it's called a tryptophan load test. So following a load of tryptophan, when we test, xanthurenic acid will be excreted in urine in larger quantities. That is xanthurenic aciduria, which indicates pyridoxal phosphate deficiency or deficiency of the enzyme 3-hydroxykynureninase. Personite syndrome. It is caused by enterochromaffin cells of ileum. They produce serotonin necessary for gastrointestinal motility. Normally, only 1% of tryptophan is channeled to serotonin synthesis, but in carcinoid tumor, 60% is diverted, leading to vasoactive phenomena and deficiency of niacin causing diarrhea and dermatitis. So carcinoid syndrome due to tumor of enterochromaffin cells of the ileum. They produce serotonin. So more serotonin is produced because of this tumor, carcinoid syndrome, and so leading to increased production of serotonin and vasoactive phenomena. Serotonin is oxidized by monoamino oxidase to 5-hydroxyindolactic acid, which is excreted in urine in large amounts and is diagnostic of carcinoid tumor. So urinary excretion of 5-hydroxyindolactic acid is diagnostic of carcinoid syndrome. Homocystinuria. It may result due to deficiency of either cystathionine synthase or cystathioninase, or pyridoxine, which is required as a coenzyme for cystathioninase and even for cystathionine synthase, or vitamin B12 methylcobamide enzyme for methionine synthase. So, or methylene transferred tetrahydrofolate reductase. So, any of them can cause deficiency of any of them can cause homocystinuria. So this methionine metabolism, if you recollect, it is methionine is first converted to S-adenosyl methionine in the presence of ATP. So S-adenosyl group is taken from ATP. S-adenosyl methionine is formed. That is the active methionine, active methyl donor. It gives away its methyl group to form S-adenosyl homocysteine. Then adenosyl group is removed. Homocysteine is formed, and this homocysteine is converted to that serine is added to form cystathionine in the presence of the cystathionine synthase, which requires pyridoxal phosphate, and cystathionine is then acted upon again by pyridoxal phosphate dependent cystathioninase, which forms cysteine and homoserine, and then the alpha ketoglutarate is formed from this. Or here homocysteine again can be converted to methionine here itself in the presence of the methyl tetrahydrofolate, which donates its methyl group to vitamin B12 to form 510 methyl white cobamide. So this methyl cobamide is formed that donates its methyl group to homocysteine to form methionine. And if there is deficiency of vitamin B12 or methyl tetrahydrofolate, this conversion of homocysteine to methionine cannot take place, so homocysteine accumulates, homocystinuria. Or this homocysteine, if it cannot be converted to cystathionine or cysteine and homoserine, then also there will be accumulation of homocysteine. Or the deficiency of pyridoxal phosphate here, or deficiency of vitamin B12 or folic acid, any of them can lead to homocystinuria. This homocystinuria may be associated with episodes of thromboembolic phenomena due to activation of Hegman's factor, leading to platelet adhesiveness and thrombosis. Accumulation causes thromboembolic phenomena due to activation of Hegman's factor. So it activates Hegman's factor, leading to platelet adhesiveness and thrombosis. Or patient may have long arms and legs with history of recurrent long bone fractures, scoliosis, genovalgum, etc. due to osteoporosis, or impaired intellectual functions and a dislocation of lens in both eyes may be present. There may be hepatomegaly. So all these symptoms may be associated with hypercystinemia or homocystinemia. So homocystinemia and homocystinuria. Histidinemia due to histidase deficiency. Elevated levels of histidine occur in urine. So normally this histidine is metabolized. So the first enzyme is histidase that converts it to urocanic acid. So histidase converts histidine to urocanic acid, which is then acted upon by a hydrolase urocanase to form 4-imidazolone 5-propionate, which is then acted upon by a hydrolase to form formiminoglutamate acid or FIGLU, which then donates its formimino group to tetrahydrofolate to form glutamate that can be metabolized. So the deficiency of histidase will result in accumulation of histidase. So this leads to elevated levels of histidine will cause mental retardation, but it may not be always present. At times, it is associated with mental retardation. Otherwise, it may pass unnoticed. Or FIGLU excretion due to folate deficiency. So this, you've seen that. So here FIGLU has to donate its formimino group to tetrahydrofolic acid to to be further metabolized to glutamate and further metabolism. So if this tetrahydrofolic acid or folic acid is deficient, glutamic acid accumulates, it cannot be metabolized, and so it will be excreted in urine. So this is the basis of the histidine load test. If you give more histidine load, so more amount of this FIGLU will be excreted in urine, which is diagnostic of the deficiency of pyridoxal, the tetrahydrofolate. So excretion due to folate deficiency, histidase converts histidine into urokinase. It's converted by urokinase to imidazole propionate. Hydrolase converts it to FIGLU, which in the presence of glutamate form aminotransferase requiring tetrahydrofolate is metabolized to glutamic acid, which participates in its metabolic functions. So deficiency of tetrahydrofolate results in excretion of FIGLU, particularly after a histidine load. I think this finishes. So another, still there is 2 minutes, okay. Pyridoxine deficiency can cause convulsions due to glutamate decarboxylate deficiency. So GABA is not formed. This enzyme, this GABA that is produced, is an inhibitor of neuronal transmission. So now neuronal transmission is not impaired, so there will be convulsions. It is a result of accumulation of glutamate. So glutamate decarboxylase is deficient. So the gamma aminobutyric acid cannot be formed, which is an inhibitor of neuronal transmission. So there is no inhibition of neuronal transmission, increased neuronal transmission leading to convulsions. Or pyridoxine deficiency can cause pellagra due to impaired action of 3-hydroxychinurenase. You have seen that, and so impaired production of niacin from tryptophan. Or homocystinuria. You have seen pyridoxal is required for cystathionase and cystathionine synthase. And pyridoxal phosphate is also necessary as a coenzyme for delta aminolevulinic acid synthase. And now, when it is not glycine from glycine succinyl CoA, so that once delta aminolevulinic acid cannot be synthesized, heme synthesis will be impaired, and so anemia occurs. So all these things can occur as a result of pyridoxal phosphate deficiency, or as a result of the enzymes which are dependent on massive doses of pyridoxal phosphate for their functioning. So vitamin responsive genetic disorders. So methylmalonic aciduria is a asymptomatic condition, mainly because excretion of only methylmalonic acid or methylmalonic aciduria, because L-methylmalonyl CoA has to be converted to succinyl CoA by an isomerase, which is dependent on 5'-deoxyadenosine cobamide. So this vitamin B12 deficiency will result in accumulation of methylmalonic acid and its excretion in urine, and of course further even propionic acid can be accumulated and increased excretion may occur. So that is methylmalonic aciduria. That finishes your amino acidopathies. So you have to be thorough with your amino acid metabolisms for being able to answer these amino acidopathies. Okay, thank you. We'll continue in the next class. Okay, thank you. Can you hear me?
Thank you, sir. So there is a question. Yes, sir.
Yes.
So in phenylketonuria, the mousy odor of urine is due to phenyl acetate or phenylacetylglutamine?
Phenylacetylglutamine.
Sir, but in some books it is written phenyl acetate, and in some MCQs there was also the answer is
effective as such. That's why it is given as phenyl acetate. But otherwise, the correct culprit is the exact culprit is the phenylacetylglutamine formation. That is the one.
Thank you, sir.